Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode number 59 of the Better Health Guy blogcast series. Today's guest is Dr. Leslie Douglas, and the topic of the show is DNA Connections. Dr. Leslie Douglas completed her undergraduate studies in biology at the University of Hawaii at Hilo before attending the University of Hawaii at Manoa, Department of Genetics and Molecular Biology. Her graduate studies focused on the phylogenetic relationships within and between tephritid species, with a sub-study involving the phylogeny of native Hawaiian avian species. Currently, she is the principal investigator and laboratory manager of DNA Connexions, a Colorado-based company focusing on bacterial, viral, fungal, and parasitic molecular-based detection assays. Her main focus is in the research and development of a PCR-based Lyme test inclusive of Borrelia burgdorferi and a number of prevalent tick-borne disease co-infections, as well as the ongoing development of various molecular-based assays. Dr. Douglas's research and patient demographics is yielding invaluable data to better understand the relationships between Lyme and other chronic conditions. And now, my interview with Dr. Leslie Douglas. DNA Connections testing for Lyme disease has been discussed now for the past couple of years. I'm excited to learn more about it today from Leslie Douglas, the lab manager of DNA Connections Laboratory. Welcome to the show, Leslie, and thanks so much for being here today.
Thank you so much. It's a pleasure to be here.
Yeah, it's great to have you. So how did you get involved in working in the realm of Lyme disease and Lyme disease testing? Did you have some personal experience that kind of led you to Lyme-related work based on your own health, or was it just the way things turned out?
You know, it's kind of funny. In graduate school, I always kind of wondered, like, how did this person become so active in tephritid and, become the central character or avian species or something? And, I just honestly, I kind of tripped and fell into it. At the time, DNA Connections was a company here in Colorado Springs called Dental DNA. And I came aboard as a lab tech and, immediately began looking at the tests that they offered and trying to improve, and really started my work on our full view test, which I think we're going to get to a little bit later in the interview. And then they said, we still have these bones of the Lyme panel. What can you do with it?
Cool.
And next month will be 3 years, actually, at what is now DNA Connexions. So it just kind of snowballed. It was great.
So I remember back to the days of dental DNA and Hal Huggins. And so how did this whole lab get started? And then kind of weaving into the response, one of the things that I hear people ask about DNA Connections is whether or not you guys are a CLIA certified lab. And so maybe you can comment on that as well. But how did this whole thing get started, and how did Hal Huggins fit into the picture?
Okay, well, before my time, unfortunately, I never did get to meet Dr. Huggins. He was sort of a leader and a stronghold in the dental and mercury toxicity campaign, one of the first, and sort of kind of labeled a heretic in some ways of, metal fillings are bad. So he was very interested in mercury toxicity and its link to ALS. Was looking for, he was a dentist, a holistic dentist, and he was looking for a laboratory to be able to discern what types of microbes, bacteria, viruses, parasites, fungi, across the board, what kind of microbes were found in root canal teeth, or teeth that had metal fillings or cavitational blood. And so he wanted these studies done, and there wasn't a place that offered that kind of testing. So he recruited some scientists, and that's how dental DNA got started years and years and years and years ago. The work on the Lyme panel actually began in 2011, and has, changed so significantly over the years. Unfortunately, Dr. Huggins passed away in 2014, and I came on board to dental DNA in February of 2015. And so, like I said, started working on the full view, and then, eventually became the lead researcher on the Lyme panel.
Excellent. Yeah, and I remember conferences years ago where Hal Huggins was there and Dental DNA, and they had a Lyme test that they were talking about at various conferences. And so was that kind of the early version of what is available now through DNA Connections, or was that an entirely different test?
It was very, very early versions. The test as it is now really wasn't fully available until about early 2016.
Okay.
There were, earlier and sort of leaner versions of it, but the general science behind it being a DNA direct test is the same premise.
And for those people that ask, is DNA Connections, are you guys a CLIA certified laboratory?
Yes, absolutely. We're a biosafety level 2 CLIA certified laboratory with the state of Colorado.
Awesome. So talk a little bit about PCR testing. So what is a PCR test in the realm of Lyme disease? It's kind of commonly understood that PCR testing is fairly insensitive. So how is the DNA Connections PCR test different from other PCR tests that may have been available in the past and may have had some false negatives?
Right. Well, PCR testing, just in general, it's called the polymerase chain reaction. And what it is, it's a targeted amplification process. You're looking for a target, or say a specific gene, and you use PCR to amplify it. If it's present, theoretically, you only need one copy, and it's an exponential replication process. So after 30 or 40, what we call amplification cycles, you'll have millions of copies of this gene. The premise for the Lyme panel is, which we kind of touched on, it's a direct DNA test. Is the DNA of the causative organism present or not? So using PCR, if it's present, we can detect it. If it's not present, then it's a negative. And PCR it's so specific, and there's things that we employ to make it even more specific and sensitive just to pick up our target amplification region. There's things, very sciencey things, like we use a very highly specialized PCR enzyme. It's not just a regular PCR enzyme called PAC. It's a high fidelity PAC polymerase. We use really long primers, upwards of over 30 base pairs long. And so what that does is it increases the specificity of them finding the target. Higher annealing temperatures, all of the things that go into the science of PCR that make this highly sensitive protocol even more sensitive to ensure that we're not getting false negatives.
So many of the historical tests in the realm of Lyme disease have been antibody-based or immune response-based. So tell us a little bit about why the DNA Connections testing approach is different, the fact that you guys are looking for antigen, and why is it better to have a direct test in the realm of Lyme disease versus a more indirect one?
Okay, very good, very, very good question. So, Borrelia burgdorferi, the causative agent of Lyme, it has really evolved to evade the immune system. And if you're looking at the immune system produces antibodies in response to the infection of the bacteria. Okay. Now, if the microbe in question, survives by evading the immune system, then you might not have that immune response to measure in an immunogenic test. Which can lead to false negatives. Individuals that suffer from chronic Lyme are compromised. They've got other issues going on. The indirect testing is the test is looking for an antibody generated by the patient, whereas our direct testing is we are looking for the DNA of the organism itself. We're not relying on the patient's immune response. We're not relying on circumventing burgdorferi's ability to evade the immune system. And regardless of the stage of disease, we can detect the DNA of the organism if it's in the sample provided, whereas immune responses vary with the different stages and progression of the disease.
Perfect. Yeah, that was a great explanation. So talk to us a little then about sensitivity and specificity in lab testing and what these mean. And then do we know how sensitive and specific the DNA Connexions Lyme panel is?
Okay. Again, we're just getting into like the nitty gritty here. The sensitivity of any kind of molecular-based assay, whether it be immunogenic, whether it be DNA or other possibilities, the sensitivity is the test's ability to find a target, either like a gene or an antibody, to find that target if it's present. So, for example, if you have a sample set of 100 known positives for a disease, in this case Lyme, we have a sample set of 100 positives, and our test identifies 97 of those 100 as positive, then your test sensitivity is 97%. Does that make sense?
Absolutely.
Okay. So the problem is, there is really no gold standard in Lyme disease testing. Okay. What if we had a sample set of 100 positives? What are those positives? Is it DNA positive? Is it Western positive? Is it CDC positive? It's a really, really hard question to answer. What we have been doing is compiling studies of individuals who, people with Lyme, are very willing to share their past results, whether it be like EIA, IFA, ELISA, Western. When with the samples that come into our lab, we get a lot of comparison results using different methods. So in-house testing and statistical analysis of this data set that we've been building, it shows our test to be extremely sensitive and very much in line with antibody testing, and actually slightly better, especially when it comes to F7 and OSPD. There can be a lot of cross-reactivity with the antibody-antigen relationship when it comes to the flagella. Ours is specific to the flagellar region of burgdorferi, where we know many, many, many hundreds of thousands of bacteria, have flagella. They have shown some cross-reactivity in Western.
And is that what sometimes shows up in other tests as a 41 positive band?
Yes.
Yeah. Okay.
Yes. And so we're showing ours to be in line and even better than immunogenic results that have been submitted. Now, our sampling, as we continue doing testing, is growing. And so those statistics are becoming more and more specific. But again, without that gold standard, what is a positive? We're working with a clinic right now let me backtrack. With the study that we're doing, we get a lot of results from different patients, but obviously, if they had a Western in 2017 and they're testing with us in 2018, you have to take into account therapies in between and what they've been doing to treat their Lyme. It's comparing apples to oranges on a kind of a difficult scale. So ideally, and what we've entered into a partnership with one of our bigger clients is that patients are taking both tests at the same time, a blood test and the urine test. And so we're very excited about those samples that are starting to come back in now. And then that way it's comparing apples to oranges, at the same time testing.
Beautiful. Yeah, that's great.
So
and I think we're going to talk about that a little bit more at the end as well. So that's kind of the sensitivity side of it. And then how about the specificity side of it?
Okay, so in general, the specificity is the test's ability to identify a target, a gene or an antibody, with little or basically no chance of it being from any other organism. Okay, And so PCR is our test is species specific. We use PCR, we use DNA sequencing. We highly utilize GenBank to ensure that what we are reporting that we're amplifying is what we're amplifying. So we know that our test is highly specific. It's sensitive in the fact that we've shown with heat-killed Borrelia that we can detect as few as 10 organisms in a sample. So I like to say, if it's in the sample, we can detect it. We're ensuring the highest level of specificity by always reviewing our primers and our sequences and our amplification products to ensure that we are on top of new organisms and new variations within the species that are being discovered, as well as, as the species are evolving, we're seeing different sizes of our amplification products. And so we take that into account as well.
So the higher the specificity, the more or the less likely it is to have a positive result that is a false positive result, essentially.
Exactly.
So if we look at the DNA Connections panel, and we know that there's a number of different organisms that you look for, and we're going to talk about that a little bit more, but Borrelia, Bartonella, Babesia, and others, how common is it to get a positive result with your test? And does that essentially mean that one or more of those organisms were identified?
Yes. Yes and yes. Our panel has 14 reactions, and it covers 11 organisms, okay, because we look at 4 regions of burgdorferi, because it has so many morphological phases and, tends to evade detection. We have 4 regions of burgdorferi. That's what we're really interested in. Any positive of those 14 reactions is considered a positive test. Now, we've broken that down as our sampling gets larger. 2 years ago when I spoke at ILAG, we had just hovering right around 90% of the panels that we got showed 1 of 14 or more as positive. And now that our sample set has grown so significantly, that number is about 83%. 83% of the panels that we get, the samples that we get and test, show at least one out of 14 reactions as a positive. Now, also, keep in mind that our sample size is skewed towards the positive. It's not the everyday person that's going to seek out a test like this. They think that they have 1 or more tick-borne infections, and that's what we're looking for. To further break down that number, of that 83% that show at least 1 or more positive, 20% of all the tests that we receive have at least 1 positive over our 4 regions for burgdorferi.
So 17% of the tests that you guys are currently doing are entirely negative, is what I'm hearing, right?
Yes.
Wow, that's
17%.
interesting. I didn't realize that it was that high. I thought it was even that the positive percentage was even higher than that. Sounds like over time that has changed. So that's interesting. So 17% are actually negative. I haven't seen very many negatives with DNA Connections testing thus far. So that's very interesting information.
Mm-hmm.
So do you think, and this is just to kind of play the devil's advocate side when I talk to people about DNA Connections testing, do you think that someday we might look back and say, oh, maybe it was too sensitive, maybe it wasn't specific enough? I mean, what do you say to those people that say that the positive rate is too high to actually consider the test a valid piece of information? And then what are you guys doing to kind of validate the panel over time so that more practitioners will accept the results and start using it?
Right. What I say is, the current standard for Lyme disease testing, which we know has a lot of problems, that current standard hasn't changed in over 20 years. It really hasn't changed with the new technologies out there to help, expand the knowledge of these understudied and underreported microbes and diseases. PCR, with its high sensitivity and specificity, with its ability to be a direct testing method, is really ideal working with this organism and with this disease.
So it sounds like you're not concerned that we may be seeing more positives than what will eventually be proven out. It sounds like you're very confident with the results that we're getting.
I am very confident with the results based on as our sampling sizes, are increasing and our net positive and net negative numbers, have been going down with that larger sampling size, as well as, again, people that send us samples, are chronically suffering and believe that this is the cause of it. So I'm very comfortable with the numbers that we're generating.
Very good. Thanks for that. Let's talk a little about herbal and or pharmaceutical antimicrobial treatment. So a couple of different angles here. So number one, should someone, if they are on antimicrobials, do they need to stop them prior to the urine collection for some period of time in order to maximize the excretion of organisms in the urine? Or is that generally not something that's been observed to be necessary?
It's nothing that we don't have recommendations. We're not clinical, so we cannot recommend to start or stop any kind of treatment for testing. We do test patients at all stages of treatment, and it would be really up to their doctors, a Lyme literate physician, to see, to establish their baseline. That's what I tell them. No matter where you are in the progression of the disease, taking the test today will establish a baseline, and then you can, because it's species specific, you can do species specific targeted therapy to try to eradicate the organisms. And so, starting a baseline of treatment is never a bad thing.
And the clinicians that I've spoken to have suggested, because I would have thought that stopping those things, let's say for a month, might have made sense so that you were able to see them then coming out in the urine. But it sounds like the clinicians that I've spoken to for the most part say they have not observed a need to stop treatments that they have their patients already on, and they still do get positive results from the testing. And so I'm not hearing people generally saying, oh yes, I tell my patients to stop before the DNA Connections testing. It sounds like even if they're on treatment, the test is still identifying organisms in their urine sample.
Yeah. I mean, if it's in the sample, we can detect it. So.
And do we think there's any reason, let's say with a traditional Western blot, which is an immune-based test, in some cases, people will find that if they put someone on treatment for a period of time, maybe they had a negative result, they put them on treatment for a period of time, the immune system now starts to see some of these organisms, you test again, and then you have a more clear positive result. Is it possible that in order to get some of these organisms to come out in the urine, that someone might find more organisms if they were on antimicrobial therapies that started then excreting them, or do we not really know if that matters?
It's a pretty, it's a convoluted question there. Many factors. At first, we know it's a highly individualized disease, and there's just so many factors. With immunogenics, it's the timing of the disease. Is it early on? You want to look at IgM for clinical relevance. If it's later, then it would be IgG. But it just kind of depends on not only the molecular results, but also the patient symptomology in response to treatments, in response to what we see in the panel. We see people, who take an initial panel and, say, they see like Duncani or Microti or something like that as a positive. And then they go into species-specific targeted therapies, and they eradicate that, and then they take another panel, and they might not see Microti, but then, you might see Ehrlichia. Maybe the Microti was sort of like the most robust infection that they were dealing with. And once that's eradicated, then, other things can start to proliferate in the system. Again, it's individualized. It's based on, symptomology. If dealing with this was easy, then everyone would do it.
Absolutely. I totally agree with you. So let's talk about the urine collection itself then. So what's the best way to collect the urine for the panel? Talk to us about some of the acceptable provocation methods and why provoking in some way is important. And then are there specific things that people may want to do in terms of these provoking approaches in order to maximize the results?
Okay. Well, there's a lot of reasons why we chose urine. One, it's really easy, and getting additional samples or samples from children, it's pretty easy comparatively to, say, blood or, cerebrospinal fluid. That's pretty difficult to come by. The urinary tract has been shown to be a site of spirochetal persistence. They like the acid, they just like hanging out in there. So after dissemination, from the blood to, the entire body, the, burgdorferi goes into the joints and the lymph and the tissues and the organs. I mean, it's everywhere. So urine provides us an ideal full body sampling of, we hope, what's going on system wide. What we recommend is ideally physical exercise. It's the easiest and the least expensive method of provocation to get a good sample. We don't want your first morning urine. So if, patient X wakes up and they void their bladder and then they exercise, loosen up the joints, loosen up the lymph, you got to give it time to get through the system, down into the urinary tract. So after you exercise, we'd like you to void your bladder again. Then we want the next sample after that. And then our kit, I'm sure you've seen our kit, I know you've seen our kit, is comprehensive in that it comes with a thermal envelope, it comes with ice packs, it comes with, everything needed, including, return shipping, 2-day shipping to get that back to us and keep it cool. Don't freeze it, keep it cool, put it in the refrigerator until you drop it off at FedEx. Now, we get a lot of phone calls of people that say, I'm pretty immobile, my joints are so sore or so inflamed or I have arthritis and I can't exercise. So we had to expand the methods that we find help to get a more comprehensive body sampling. Now we've got full body massage, deep tissue massage, or there's been some sauna therapy, some ultraviolet therapies that different practitioners have tried, and with dramatic results. They'll send us like pre and post of whatever treatment that they're trying. And we're always interested in samples like that to see, other ways to help get this organism out in the open to, get into the sample so we can detect it. All we need is 10. That's it. All we need is 10.
So if you took a sauna, for example, or you got a massage, you would want to void the next urine and then you would want to collect and send the subsequent one. I know that I've heard Dr. Klinghart's talked about using ultrasound, I believe, as another way to potentially provoke this using different kinds of light and so on. So is there one that seems to be better than the other? Is there one that you really recommend? It sounds like if someone can do exercise, that's what you recommend. Do they all seem to be about equal in terms of what you find from a test perspective?
It's really hard. It's really hard to say. I know that any kind of provocational therapy is better than none. And again, frustratingly, because it's so highly individualized, it's going to be different for every patient.
Right. And if they do something
some sort
like
of physical activity.
And if they do something, and does the morning time really matter? Or if they do like the massage or whatever, later in the day is fine. Okay, great. So let's talk about...
we just don't want the first morning urine because it's got a lot of metabolic waste and molecular debris.
Perfect. So let's talk a little bit about after a tick bite, how long might it take before we would be able to potentially find these organisms using the DNA Connections panel? I mean, in my mind, it would be relatively quick, but do we know, compared to the immune-based assays, which often takes weeks or longer before you would have an immune response, how quickly might we be able to detect the antigen in your panel after an exposure?
Okay, well, first, just to correct, we're not looking for antigens. We're looking for the DNA of the organism itself. And what we're waiting for after that tick bite is that process of dissemination where it goes from the bloodstream everywhere else, like we discussed, the joints, the tissues, the muscles, the organs, things like that. That process of dissemination, I don't know any large-scale studies that have documented anything about that. We just know that it happens. It's individualized. We don't know how long that takes. I mean, theoretically, it would be rather quickly, but in every person, it's going to be different. It depends, how apt their immune system is to target that organism and eradicate it before it even leaves the bloodstream. So, typically, depending on, the level of IgM production, very, very early on, days to maybe a couple weeks after the tick bite, IgM might be your better bet. But again, individualized, depends on the immune system, depends on how the individual is combating the organism.
Plus, it seems so tricky because unless we knew they had a negative DNA Connections panel prior to their tick bite, even if something showed up after the tick bite, we don't necessarily know whether that was from the tick bite or they had a previous exposure and just never really developed enough symptoms to doing testing, right? So it's a tricky,
absolutely
tricky situation.
Very tricky.
Yeah, absolutely. So when you receive a sample, what's the process that sample goes through to determine if there's a positive or negative result? Can you kind of walk us through what you guys do with the sample?
Yeah, absolutely. So we receive a sample, and through the intake process, we make sure that it's acceptable. Our minimum volume that we can work with is 30 mLs of urine. I mean, our urine cup holds like 150, and it surprises me when people just give us a teeny tiny little amount, help me out here. So, we assess whether it's an acceptable or a rejectable sample. Assuming it's accepted, what we do is we concentrate it down, and then go into our DNA extraction process. Now, our process targets live cellular material. People are always asking, well, is it a dead Is it a dead organism? Or is it just random degraded DNA? And, the answer is we're not totally sure. We can talk about the statistics on that because it's highly unlikely that it's just random degraded DNA. But our extraction process targets live cellular material. And then what we do is we gauge the integrity and the purity of the extracted DNA sample using nanodrop technology. It's, the newest, greatest version of spectrophotometry using ultraviolet light. So we make sure that there's enough DNA and that it's not contaminated with proteins or other things that could inhibit the PCR reactions. Then we run our Lyme PCR. Every patient, every positive and every negative is run in duplicate for consensus. We, again, use that high fidelity Taq polymerase and extra long primers to make it as specific as possible. And then we visualize our results using UV electrophoresis. So we essentially separate out the amplification products by size and then rank them against what they call a ladder of known sizes, where we can gauge whether it's a positive amplification, meaning we were able to detect and amplify the target region of the positive organism, or if there's no amplification product, then it's negative.
And that's why
kind of it in a nutshell.
That's why you're the smart one.
Right. Cool. Well, come on down, come to Colorado, and I'll take you through the whole excruciating process.
Awesome. That'd be fun. So after you receive the sample at the lab, how long does it generally take for someone to get their results back?
Well, samples are processed on kind of like the date that we receive it and log it. Right now we're at about a 9-day turnaround. 9 or 10 day turnaround. I know frustratingly, when we were moving into our larger facility, we were about a month turnaround. So we've got like 9 lab techs, and myself working to keep these samples, quality over quantity and, get these processed. There is a rush option, which guarantees your results in 7 working days.
Excellent. That's good. Yeah, I know that time's come down quite a lot. So congratulations on that,
Yeah.
because that's really important.
Thank you. Thank
So
you.
what organisms, let's talk about the organisms that the panel does look for. And then are you
Okay.
continuing to, or do you have plans to add additional organisms to the Lyme panel over time?
Yes. Okay. So, well, of course, we look at burgdorferi. We look at 4 regions of burgdorferi. We have 2 other species of Borrelia. We've got 3 Babesia, 3 Bartonella, Ehrlichia, and Anaplasma. All of these are looked at the species-specific level. So if I say it's Babesia microti, it's not something else. It's not a different species within that genus. Yes, we are working very hard. We have a long list of organisms that we are looking to expand to the panel. People call me all the time, like, can you test for this? Can you test for this? It's a long process to add to the panel, but we're right at the precipice of adding more organisms. It should be within the next couple of months.
Awesome. That's exciting.
Yeah,
So
very excited.
let's talk a little bit about how the organisms in the current panel were chosen. And then are all of them ones that are believed to lead potentially to human disease? And so, for example, I've gotten this question from a few people, Bartonella bacilliformis, Babesia divergens, others on the test that aren't really commonly things that, to my knowledge, that Lyme literate doctors look for or discuss within the Lyme community so much. So why are those part of the panel? And do we think that they potentially are associated with human disease or human illness?
Yeah. Okay. So, the original organisms that were on the panel were already incorporated, most of them already incorporated when I came on board. Right at the end, I had added Miyamoti and Recurrentus, both of the Borrelia genus. So Bartonella bacilliformis is really interesting because, it is a bacteria. It is, it's the causative agent of Carrier's disease. This was on the panel when I came on board. It's prevalent in North and South America, but really in South America. So I get this call all the time going, I've never been to South America. How can I have this? Well, especially this one and divergence, but especially Bartonella bacilliformis, I really feel like it's just like Lyme, understudied and underreported. It's on fleas. It's transmitted by fleas, body lice, and sand flies, which are, prevalent everywhere. Go to a beach, it's going to happen. And, bacilliformis is a lot more prevalent, what we find on the panel, than a lot of our physicians think. And, through looking at GenBank and looking at our primers and having these amplification products sequenced, it's solid based on the information available in GenBank. This amplification product came from Bartonella bacilliformis. As far as Babesia divergens, the other organism that you would ask me about, yes, it's a blood parasite. Yes, it's a protozoan, but it's also transmitted by the Azotes tick. So, it's out there, and the lab manager before me had the foresight to, really kind of think about what needed to be on this panel at the time and, to present day.
Excellent. Very good. So you kind of alluded to this already, but I just want it to be really clear for people. So if there's an organism like Borrelia or Babesia, but not a specific strain that you test for, let's say, for example, Borrelia afzelii or Borrelia guerinii or some of those European type Borrelias, would those show up in any way on the DNA Connections panel? And if not, are those ones that are potentially being added?
No and yes. Being species specific is kind of like a double-edged sword. It's what sets us apart. We're not just saying some Borrelia or some Babesia. We're saying, Borrelia miyamoti or, Babesia duncani, again, that targeted specific treatment. But, a genus is very broad. And then you do have, species and subspecies that will evolve over time, looking at the European, are they different species? Or are they different strains of the same species? So if it's not one of the organisms that's currently on the panel, we won't pick it up because we're so targeted. And so that's the no. And the yes is we are very excited that we're going to be adding new organisms to the panel, that people have been asking us for so long. It just takes a really long time to get all the R&D done.
Would there be any value just from an informational perspective in looking at the genus level? So a practitioner knew, oh, this person has some type of Borrelia, even though it may not be one of the ones that can be more specifically named, or do we think that's not necessarily helpful?
Again, yes and no. The genus level is extremely broad. And again, I'm in the sort of detection realm. I'm not in the treatment realm. Would the treatment vary for different species within a genus? If the answer is yes, then the information will be valuable. But again, what sets us apart is that we're at the species-specific level.
Perfect. So you talk about Borrelia, and you mentioned that in your panel you look at several different regions to attempt to really find this organism. So is that something similar in terms of the co-infections? Like, why do we look at several regions for Borrelia, and then do we look at several regions of these other microbes that are on the panel as well, or not?
We look at, for the co-infections, we look at one region. Of course, we find them very interesting, but really, most interest is, the causative agent of Lyme, Borrelia burgdorferi. Because it's so evasive, we do look at 4 regions. Evasive as in it has different morphological forms, a cyst, a bleb, spirochete, it can go dormant. It is sneaky. So with comprehensive body sampling, with taking your sample for our directions with some sort of provocation, we're with us looking for not one, but actually 4 different individual reactions to try to detect any stage of this organism in any stage of the disease. We're just trying to be comprehensive, giving people the answers that they need.
Very good. When we find something in your test and we find that there is some DNA of an organism that's been identified, do we know if that means that the microbe is actually active infection versus potentially a dead organism that is just present in the body and hasn't been fully excreted? Obviously, I guess if it's a urine test, it has been excreted, but when it comes out, can we differentiate between active infection and dead or dying organism?
Okay. The answer to that is we don't know. The way that we combat that is, one, our process, like I said, we target live cellular material. Okay, that's number one. The genome, this is where math is our friend. Okay, the genome size, how many base pairs the genome of burgdorferi is, it's about 1.5 million base pairs. Every organism has 1.5 million base pairs of DNA. What we are looking for, the amplification sizes that we are looking for is between 250 base pairs and 1,200 base pairs out of 1.5 million. So if it was just a random dead or degraded sheared DNA being excreted in the urine, what are the odds that we're going to find our 250 base pair target? If it was random sheared DNA, it would just be, a plethora of pieces, essentially. So the first thing that we do when I said that we concentrate down the sample is to wash away anything, what they call extracellular, anything that's not involved in the actual live cells in the sample that we're receiving. So statistically, it's entirely unlikely that it is just a random dead piece of DNA. I mean,
okay. Yeah, that's a great explanation.
Really weird.
Perfect.
Okay.
So
okay.
In people that have a positive panel and then do some treatment, is it common that they then end up with a negative panel? So I know in my case, I had Lyme and co-infections for years, treated them for years, didn't have any symptoms that I attributed to Lyme or co-infections anymore, but did still find some positives in your panel. So is it common that people that are successfully treated, become asymptomatic, feel really well, that they would then show a fully negative test? Or is it common that we still do see some positives, even though they may not still be expressing symptoms of the condition?
Both possibilities. I've seen both possibilities where they've gone from a positive to a negative panel. They've gone from, a positive, say they have, 1, 7, and 12 as a positive. And then I talked to you a little earlier about how if, one of those infections is a more robust infection and it's sort of, inhibiting another microbe from flourishing with that species-specific targeted therapy, you'll get rid of like microbe number 7 on the panel, and then all of a sudden 9 will start being able to proliferate. So, I've seen panels that have gone from positive to negative. I've seen panels that have gone from positive with certain microbes, then with treatment they find other microbes, start to flourish. I always say, as with any molecular-based panel, any molecular-based test, patient symptomology has to be taken into account. If you're feeling good and you're asymptomatic, do you want to go through additional treatment just to achieve that negative panel? Again, not my realm. You need to, discuss treatment options with your physician.
It would be really cool to take those people that had highly positive DNA Connections panels that became completely negative and then be able to match that back to what treatments were their doctors implementing to see if patterns come up over time. I know that would be a big project and not necessarily.
Well, it would be a little daunting. But, again, what's so difficult is that there's just not one therapy.
Right.
And everyone's not going to react the same way. Plus, a lot of these patients that are chronically suffering, they're not just doing one. They're doing several different therapies, be it traditional medicine, or non-traditional therapies. And so it's just like in science, you got to vary one thing at a time to figure out exactly what's going on. It'd be hard to figure out what was. I'm sure they're just grateful to be feeling better.
Yeah, absolutely. So with all the panels that you guys have done to date, have you been able to glean any information about the prevalence of the various co-infections in the samples that you've tested? Are there specific organisms that stand out much more commonly than others?
We see a lot of Henselei, a lot of people, we see a lot of Bacilliformis, of course, burgdorferi, that's what we're looking for. As far as what we don't see a lot of is we really don't see a lot of anaplasma, Phagocytophilium. We really don't see a lot of Bartonella quintana, just a few percentages, less than 10 for sure. Miyamoti is becoming more and more prevalent, not anywhere near, say, Microtia or Duncani, not in any way, shape, or form, but we are seeing more Miyamoti. As far as, kind of geographically mapping that, it's impossible. We look and we study all of the optional demographic information that we have with every kit. But, people say, oh, I got bit by a tick when I was a kid at the beach, or, they just don't know where they picked up the disease. So it's really hard to figure out the geographical demographics of relevance and prevalence.
Would you say it's more common to observe Bartonella or Babesia?
Ooh. I would have to say, because we have 3 of each on the panel, and because we don't see hardly any Quintana, it kind of downgrades, really to 2 prevalent options of Bartonella versus Babesia. So I'm going to go with Babesia on that one.
Okay. Sounds like we're doing a game show now.
That's what I was just thinking. It does. It sounds like
Awesome.
we're doing a game show.
So can you tell us anything about some of the things that you're planning to add to the panel in the future?
We are looking at, people ask us for stuff all the time. Things that we're looking for is Mycoplasma, Epstein-Barr, and of course, I probably don't say them right, but Grignii, Axelli, Bissetti, all of those are in the works. Starry eye or starry, we're looking for that. All the clinics that we have, that we're affiliated with across the country, they want it based on, geographic relevance, what they think that they should be seeing. And so, we're just, it's based on the information available and, how we can use that information to develop new PCR primers.
And it seems like that the geographical piece seems like it just changes so fast anyway. I mean, I remember years ago when Babesia wa1, which was from Washington State, that eventually became Babesia duncani, that now is, pretty much everywhere. So it seems like it gets around pretty quickly. That's exciting. I'm excited about mycoplasma. I think that's a very common issue in people with Lyme and similar conditions as well. Are you guys looking at like Mycoplasma pneumoniae or fermentans or several possible mycoplasmas as well?
There's several that we're looking at, with pneumonia is one of them for sure.
Awesome. Yay. That's exciting. I'm very happy about the panel continuing to expand. So that's great. So talk to us a little, if someone's interested in doing the panel, do they have to have a doctor order it? Can they order it directly as the patient? What's the cost? And does insurance cover it?
Okay. Right now, you can get it through your doctor. You can go on our website and order a kit individually. I don't know how much longer that option is going to be available because we are, in the first part of our FDA affiliation. The FDA, after we're accredited by them, will, as far as we understand, will be no longer, you'll have to get the kit through a doctor. But right now, you can go to DNAconnections.com and, self-order a kit. The panel is $500, and that includes the cost of the kit. And like I said, we're at about a 9-day turnaround, and you can always do the rush option as well.
And do you see insurance ever covering the panel, or is that generally a no?
Oh, right. We get that question all the time, and what we say is, you need to talk to your doctor, you need to talk to your insurance company. We don't deal with insurance at all. I do know that we've had some Anthem Blue Cross companies have paid for it, just because, physicians or different practitioners will let us know, oh, hey, I got remittance for your test. As molecular-based testing is becoming more and more used and acceptable, I would think that the insurance companies would come on board, but that's kind of like the client will have to deal with that themselves.
Well, I mean, and the good thing is $500, why that is still a reasonable amount of money for many people dealing with Lyme. If you were to do testing for all of the things that you guys have on the panel, it would be significantly more than that if you went through other lab options that are available. So, I mean, I think it's still a very reasonable option for the number of things that you guys are looking at. Yeah. So you mentioned,
and knowing how much work goes behind it, I think it's a very affordable number.
Yeah, very good. Thanks. So you mentioned the 2-tiered kind of testing that you guys are doing and starting to collaborate with Armin Labs.
Yeah.
So what are you guys hoping to get from that collaboration? Is there some specific questions that you're hoping to answer?
Well, like we discussed earlier, the method of testing, sort of the current standard, hasn't changed in like 20 years. So some practitioners are still uncomfortable with the thought of using DNA. Because it's not what what their progenitors have taught them, and it's not what they know to be a standard. So we want to give people a choice where, you can do one, either or both. It'll help. It's basically, a partnership for co-validation, using blood, using urine, and looking at, both direct and indirect testing needs, really covering the bases.
And if someone's interested in doing that, do they then need to have their doctor work directly with Armin Labs, or is that also somehow coordinated through you where they get both sets of whatever they need to do the dual testing?
I know that the answer is I don't know, but I can find out for you. I can find out for your listeners. I know that we're in the final stages of launching the collaboration, and I would think that it would be on both companies' websites when it's live and active. I'm sure they'll think of a very easy and simple way for people to find that answer.
Perfect. Can people send you a tick and do the same profile that you do today on urine? It seems like a lot of the tick testing that's available doesn't really look for co-infections, or they have to pay for each additional test. So can someone do this panel on an actual tick?
Right. I mean, we sort of kind of started looking into that. I know that there are places that offer some options. It's something that I'm interested in, but it's not really a test that, it's nothing that we offer now. They can send me a tick and I can, use it and store it for research purposes only. There would have to be, there's not a whole lot of DNA available in a tick, and so it's a little more difficult. I haven't quite nailed down that extraction process. It's something that I'm working on because I'm interested in it, but nothing that I think that we will offer on like a business-wide scale.
Plus, how are you going to get the tick to pee into that little container? I mean, that's... And you may end up getting hundreds of ticks a day in your mailbox there at the lab too. So it's fun.
Right.
Okay, so let's talk a little about the dental testing that you guys do. You mentioned earlier the root canals and so on, and that they can have many different organisms. So what can you tell us about that? Do root canals tend to harbor lots of different organisms? If someone's interested in that, what is the dental testing that you offer?
Okay. So that panel is called the FullView panel. It's a direct test. It's DNA PCR based. It's a panel of 88 different microbes. That's 88 separate reactions: bacteria, viruses, parasites, and fungi. Typically, it is based on dental samples, extracted teeth, cavitational blood, just regular tooth blood, say during an extraction. We can also do a full mouth survey with a product called Superflash or a saline rinse. Now, for your viewers that don't know, a cavitation is different than just regular blood from the mouth. So a lot of us, being the ages that we are, we've had wisdom teeth extracted. Now, of course, I had every complication in the book. I had an infection, I had dry socket, and eventually it healed over and I've gone on with my life. Well, in that hole, that void that used to be my wisdom tooth, while I'm going through healing and, regular eating and drinking, the regular flora in your mouth, and the infection that I dealt with, once it heals over, those bacteria, and parasites are live in that voided area that is now healed over. So a lot of people, who suffer chronically, they go, well, is it an immune response to the root canal material for root canals in my mouth? Is it because I have metal fillings? Is it because I have a huge little microflora in the area where I used to have a wisdom tooth? Really, your system and, your overall health and how you feel and your immune system, it's all related from your mouth to your anus, and so like Dr. Huggins originally, hypothesized is that everything is related to what's in your mouth, and your immune response to it. So the FullView looks at 88 different, predominantly bacteria, but again, bacteria, viruses, parasites, and fungi. And a lot of them are present in the normal oral flora. But in people who are sick and have chronic conditions, or other issues that are taxing their immune system, the relative amount of these microbes give doctors a real clear glimpse of what's going on in the system. Some people get Lyme and their immune system takes care of it and they never know they have it and they go on with their life and they're none the wiser. Some people contract Lyme and they chronically suffer for 20 years. It's like they're run over by a truck and they can't function. And why is that? Is it because we've got bacteria stuck in cavitational pockets in our mouth? And there's a whole school of thought of holistic dentistry that says, that's why the immune system can't fight Lyme because they're fighting all these other chronic microbes that shouldn't be there or are part of the flora but shouldn't be in the levels that these people are, that we're detecting in the mouth and applying that to a systemic level of the overall health of the patient.
So you mentioned there's 88 different organisms on this dental full view test. My understanding is that a fairly high number of organisms can often be found in root canals and cavitation. So how many organisms might someone see in a root canal or a cavitation? Are we talking like 3 or 4? Are we talking like 50? Are we?
Okay, sure. Our average panel has between 12 and 17 positive organisms. Now, whereas the Lyme panel report is positive or negative, the full view is positive or negative, and if you're positive, how positive are you, and how devastating any particular microbe that we find is. The overall pathogenicity of the organism. You could have a huge amount of, a very, very brightly lit amplification product of, say, Candida albicans, or a very, very, very tiny amount of something extremely devastating, like botulism. Well, the botulism, even in a very, very small amount, is going to, trump Candida, any day of the week. And so it's not just positive, it's how positive are you. Really bad panels, I think the highest I've seen, again, our average is between 12 and 17. The highest I've seen is about 37 out of 88 in one panel.
That's amazing. But yeah, you can definitely see we're having that many different organisms. And I've had my cavitation journey and surgery and all that kind of stuff too. And I've often wondered the same as what you had suggested, that, is it possible that those things just brewing in there for years and decades is kind of one of the things that sets the stage for the immune system to not be able to respond to something like Lyme? Can the full view test be done if someone was curious about, taking a blood sample and seeing what their systemic burden was? Would that make sense? Or are these organisms more focused on things that are more likely to be found in the dental cavity?
Yeah, we have done multiple stages and different extraction procedures on venous draws, and it's not a clear picture. We usually only pick up 2 or 3 organisms. It's not things that are, the issue is not what is circulating in the bloodstream. I think it's just more of a systemic picture of the oral cavity. And of course, just like the Lyme panel, which is a urine collection, there's all kinds of different kits that we offer for the full view panel. We have teeth, we have saline, we have superfloss, blood. There's all kinds of different kits, and those can also be ordered on the website. If somebody just wants to do a full view on their own because they're interested, they could do the superfloss or the saline. Obviously, we're not recommending that you extract your own teeth and send them to us. That would be under the care of your dentist.
Thanks for clarifying. Yeah.
Yeah. Okay.
So one of the organisms in Dr. Richie Shoemaker's work is MARCoNS, or multiple antibiotic-resistant coagulase-negative staph. It's often found in the sinuses. And more recently, in the past couple of years, doctors like Dr. Mary Ackerley have found this organism in cavitations, in root canals. I've talked to one person that found it in an ear piercing. Is that organism one of the 88 organisms that's in the full view panel that you guys offer?
Well, we do have several species of both staph and strep, but discerning coagulase negative versus coagulase positive is not something that we can do on this level.
Okay, good. All right, so my last question is always the same, and that is, what are some of the key things that you do on a daily basis in support of your own health?
In support of my own health? Well, positive thinking, and positive reaffirmations I find extremely important in day-to-day health and well-being. As your listeners can tell, I have a very interesting and challenging profession, and while I enjoy the puzzle, I do try to leave that at the office as much as possible, which is not always the case. I don't smoke. I very rarely drink, and I do try to exercise and eat well. I've been lucky to not have any specific chronic conditions, and hope to keep it that way.
Very good. Very good. So are there any other things that we didn't cover about what you guys offer? I think we covered things fairly well, but any last comments or anything that comes up that you think we need to mention before we wrap up?
No, just that we have a great team here who works really, really, hard to, provide the highest quality of molecular-based testing available.
Awesome. This has been super fun for me. I mean, I've known about the panel for a while. You and I have certainly met at several conferences.
Yeah.
I appreciate the work that you guys are doing to try to bring new options and new ways of exploring the potential for Lyme and co-infections. As we've talked about, it's a complex puzzle. It's not always easy to find the answers. And I think having your test available is certainly a fantastic tool. And so thank you so much for spending time with us today. And I just appreciate all that you do. And I look forward to seeing you at an upcoming event.
Thank you so much. And thank you for getting the word out about our company and what we're trying to accomplish here. We really appreciate your time.
Thanks so much, Dr. Douglas. Bye-bye. To learn more about today's guest, visit DNAconnections.com. That's DNA Connections, CONNEXIONS.com. DNAconnections.com. Thanks for your interest in today's show. If you'd like to follow me on Facebook or Twitter, you can find me there as Better Health Guy. To support the show, please visit betterhealthguy.com/donate. If you'd like to be added to my newsletter, visit betterhealthguy.com/newsletters. And this and other shows can be found on YouTube, iTunes, Google Play, Stitcher, and Spotify.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.